We also focused on the bone loss during the healing phase. We have a meta-analysis by Naini that found a 1.3 to 1.5 millimeter horizontal bone loss. And there are 600 articles which measured it and found between 1 and 3.1 millimeter bone loss. And we found for the classical GBR 0.9 millimeters and for the associated 2.1. And in percentage, it's almost the same. It's around 28-29%. If we want to understand the reason that could explain this bone loss during the healing phase, because you're not happy, you're doing a sausage, you're doing a graft, big graft, and then you lose some bone, you want to understand why. You can find three potential reasons for that. The resorption, remodeling of the blood clots and the particles, the soft tissue pressure, and if you packed your graft well enough or not. Just for the one who use the PRF and things like that, who can mix it with the particles, it's something that will resolve. So it will augment the resorption of the volume at the end. The horizontal bone remodeling after implant placement has been shown to be 0.5 millimeters. And we have a finite analysis element by Yoda in 2017. And they found that if the buccal bone thickness is less than 1.5 millimeter, we will have between 20 and 45% horizontal bone loss. And if the buccal bone thickness is more than 3 millimeters, you won't have any bone loss. This is a finite element analysis, but that's in the line of having a buccal plate wide enough. But more interesting now, about the vertical bone remodeling after implant placement. Literature agrees for 25 years that the thinner the bone place and the more the vertical bone loss. But Sprague did a huge study, multi-center study, 3,000 patients in the year 2000. At that time, there were no CBCTs. So they used a paleo probe. And they measured the buccal bone thickness at the implant placement and after uncovery. And they found the bone thickness threshold of 2 millimeters. If they had less than 2 millimeters buccal bone thickness, they lose the lost bone vertically. And if they had more, they keep their bone. And Monnier, on a preclinical study on the dog, and this year on a review, show it and explain this with the avascular necrosis. Why do you lose your bone? Because if the bone is too thin around your implant, it can't be vascularized well enough. So it will die and resolve. And you know that if the rough surface is exposed in the sulcus, you have a higher risk of pericarditis. So the implant should be completely surrounded by a bone volume of at least 1.5 to 2 millimeters on every surface, and even more in the aesthetic area. 2 to 4 millimeters, under advice 2 to 4 millimeters. And if you have a native bone or a grafted bone, it's the same. So, you expect a mean horizontal bone loss during the healing phase of 1.5 millimeters. You have a bone remodeling after implant placement of 0.5 millimeters, so you have a total expected bone loss of 2 millimeters. You want 2 millimeters all around your implant. So for a standard 4 millimeter diameter implant, you want 2 millimeters on the limb wall, 4 millimeter diameter implant, and 4 millimeters on the buccal because you want 2 and you will lose 2. So you need, after your graft, to have a 10 millimeter total width. And at implant placement, you need 2.5 on the buccal because you will lose 0.5, 4 millimeter diameter implant, and 2 millimeter on the limb wall. So you need an 8.5 millimeter width. And the good news is that we can. With this technique, we can. So this is now a video of the sausage technique. You do the incision and you take great care of removing every remnant soft tissue. You remove every periosteum that adhere to the bone. For this patient, we did a sinus with the piezo device. So you always start with the sinus and you end up with the sausage. So this is a very small sinus. You lift up the membrane, you place some biomass, and you put the window back on. You do the perforations. And then you place the membrane, palatal first. You fixate it with 2 pins. Then you place the mixture. You just place it where you want, but you don't try to pack it at that time. And then you pull back the membrane, you stretch a little bit and you pin it on the distal. And another one, you pin, you stretch. These are the push-up pins. You can see the elasticity of the membrane. It's key to the immobilization of the graft. And with the Mini-Me, this instrument you can see, you evaluate the compaction. The construction should feel as dense as possible. So you pack it well, and at the end you put a little more mixture. And you stretch again. Until it can't breathe anymore. So you need a complete crystal stability of the graft. And this is a magic pin. The last pin, you stretch a little bit, and you put the last pin in the middle. And then you cut the extra membrane. Be careful to the flap. Don't cut the flap. Classical mistake. So then we are doing the buccal flap advancement. It's performed using the periosteoelastic technique. So first you do a periosteel incision that you didn't see there, but you will see later. on other cases. Then you get the periosteal cross bundles, and right now you do the elastic fiber separation with the mini-me. And then you suture in 2 layers. So first layer is sutured with a horizontal mattress technique. Horizontal mattress that are done 5 millimeters from the incision line, every 5 millimeters. Another horizontal cross mattress suture. Mattress suture. And then another one. So the first layer is sutured, and now we are doing the second layer with interrupted single suture. I use in my practice the 6.0, but for the workshop today you will use the same, and you can use the same anyway, same suture for both, for the first layer and for the second layer. And then you suture the vertical incision.
Good. Perfect.
So this is the sutures and the healing. So we superimpose the base sensitivity and the healing sensitivity. And this is the reopening. This is how the wrist should be after healing. You should not have a lot of biomaterials particles. You should have some, a little bit like you see, but this is the way it should be. Not too much. And the flap should be raised easily. And then you can see some pins. Some of them you can remove some of them easily, especially the palatal pins. But some of them on the buccal are included in the graft. And don't destroy your graft to remove the pins. You just let the pins. It's titanium, you don't risk anything. Then we place the implant with a digital guide, and I use the 3 fines, specific 3 fines, because I want to do histologies. But we also, we can keep the bone to, if you have a problem or if you want to improve a little bit your graft somewhere, you can do the same and use the cross to help with recontouring your graft. If the core don't come with the 3 fine, you have a specific tool to take it out. Then you finish the drilling and you place the implant. And you can see that I'm not able to finalize the implant placement with the end piece. I need a key because the bone, the regenerated bone, is really hard, is really dense. It's a very good quality bone.
Mạnh quá, đúng rồi. Bật hơi thở gì vậy? 780. Bề mặt cứng là phần kết nối cứng rồi. Kết nối ra giữa hai lớp. Cái phần độ dày của bạn.
So this is the healing. So you can see the distended vestibule. So we did a strip technique. This is the healing. The healing after 2 months. And the recovery. The end results. So these are, I summarized here for you the 5 characteristics that you should have to call your regeneration a sausage. Because everybody does GBR, everybody is doing many things, and everybody is talking about sausage, but few knows really about the characteristics. So this is what you should do if you want to call your regeneration a sausage. You should use a mixture made of TBPM and particulates autogenous spore. You should use a stretchable, fast resorbable collagen membrane. You should use pins, of course. You should pack your graft very well. And you should have a final inflated shape, as we've seen just before. These are the 4 principles for predictable GBR developed by Wong in 2006, but still the rules are remaining the same. First is the primary wound closure. If you don't close your flap without tension, you will expose, and we will see that with the complications, we will have many problems. Angiogenesis, the reason why we are doing the perforations, even on the maxilla. The space maintenance is about the shape of your graft, about your packing, and the stability is what we said together, that we said before. If you don't pack enough, the graft won't be stabilized enough, so it will move. So the stability of the blood clot won't be maintained, and potentially you will have a fibrous graft. Some dentists say maybe it's not necessary to do the perforations. But we have some studies that are showing that it's better. At the mandible, you can really feel it by yourself that if you do not do the perforations, that won't bleed the same. You won't have the same interlock with the native bone. At the maxilla, maybe it's less useful, but I think anyway it's useful. And we know that the potential for biologic integration is not the same. If we have a cortical bone, or if we have a very live bone, like this one. So let's see an example. We have here a horizontal defect with a knife edge ridge. So first we do the sinus, then we place articulate graft, we follow over the membrane, and this is one of the first sausage I did, and normally you should place your pin, your measured pin, before the teeth, here. You should not place it here because if you really want to be far away the roots, you will be too close of the sites where you want to place your implants. So potentially, you won't have reach wide enough. I did this. You want to know why I did this? Because I didn't choose my membrane properly. I chose a too small membrane, so I had to deal with this. But still, it's a nice mistake because this is the beautiful bone that we got. For this patient, we gained 8.7 millimeters, and you can see the graft, the sandwich graft, the sinus graft, and the bone graft, the GBR, the sausage. And this is the beautiful picture that we got, and that has been chosen for the cover of the issue of the journal our article was published in. Because you can really see that with this composite graft, the bone regeneration can be performed and maintained out of the genetic bone housing. You can really see the balloon that is far away from the genetic housing. And this is 6 months after the graft. If you had a xenograft in this graft, if it was not xenograft, for sure it was a flat shape. And if it was only autograft, the same. So this is the end result and the checkup after 2 years. And we know that these results are stable over time because Orban published a 5-year study with a mean periannual bone loss consistent with the standards for implant success. Here is a patient with orovantral communication and a horizontal defect with a 2 mm crest width. So the technique is to dissect the flap at the location of the sinus communication. Then you create the sinus window at the optimal place where you should do it. And then you lift up the membrane and you see the edges of the defect appearing. Urban calls this technique the atomic bomb because of the shape. And then you put the biomaterial. On the top you add some autogenous bone, and then biomaterial again. This is a sagittal sandwich bone augmentation technique described by Urban in 2010, and he also did a 10-year retrospective study with this technique with very few marginal bone loss after 10 years. So the sagittal sandwich technique involves placing autogenous bone in the area of future implant placement and protective layers of DBBM at the medial and lateral borders. So it is especially indicated where the sinus has a low osteogenic potential, like this one with orovantral communication, or sometimes you have a really big bony shell, so you have a very low osteogenic potential. But Professor Urban used this technique for every sinus he is doing, for you to know. So then you close the window, you do the sausage, you stretch the membrane, you wait for 6 months, and you get a beautiful bone. We have now a 9 mm crest width, and the orovantral communication is now closed. Here is the regeneration bone, and we gained a little bit bone on the molar also, right here, because we had a defect at this location before, remember? So when you reopen, you always check the gingival thickness. So this is an adequate 4 mm gingival thickness. So we don't need to deepen it. You place the implants, and we have enough bone thickness all around our implants. This is the distorted vestibule, and these are the mucogingival junction that we had at the beginning and after the surgery, after the healing. So we can compare. And so we need to fix this. So first you reflect a partial thickness flap, you suture it up, then you place a strip under, and then you place the matrix under the strip, and we suture it. So for this case, we took the strip from the labial side. That's the difference. So this is a combination of a strip gingival graft and the xenogenic collagen matrix. This is the uncovering, and for this case, we were even able to get the papilla. The end results, and check-up after 2 years. And you can see that when we have a labial strip, the aesthetic results is better. The strip is less white, is less visible. So the strip acts as a barrier for mucosal cells. That's the reason why you should connect the strip to the keratinized tissue everywhere. And you do a keratinized garden in the middle. The keratinized garden, then you place your matrix. In the matrix, the cells are coming, the keratinized cells, and you will have keratinized tissue. If you do not connect the keratinized strip to the keratinized tissue, you will have mucosal cells coming in, and you will have a site without keratinized tissue. So the strip technique has been described and developed by Professor Urban, but the founders of the technique are Alan Tage. In the 90s, they had the idea of an apical reposition flap associated with several strips. So with this, they could predictably achieve a vestibular deepening and augmentation of keratinized tissue. But it was too much strips and not beautiful and invasive. Then second is Erfurt, who understood the principle of the keratinized garden, but this keratinized tissue was not a strip, it was the part of the flap. For example, it didn't work at the mandible. And then Professor Urban developed the fine strip technique with the best of these two ideas. So he developed it in 2015, and then he developed the labial strip in 2020, and in 2019 he did a huge, great histological study because some dentists said that potentially maybe it was not keratinized tissue in the middle. So he had to prove with a histological study. He used the immunofluorescence staining with keratin antibodies, and the control group was the palate, and he showed that yes, it was keratinized tissue in the middle. So this technique enables us to increase the width of keratinized gingiva, relocate the mucogingival junction, and deepen the vestibule in one surgery. That is the main advantage of this technique. It's a technique that is less invasive, less painful, you have less tissue shrinkage than many other techniques for this. And about the collagen matrix, because many dentists ask me, do we really need to use the collagen matrix? The matrix accelerates the initial wound healing and result in a better color match. But what I do in my practice is when you have a one teeth defect or one tooth defect or even two, or if you are on the mandible, because on the mandible your strips are smaller, you don't need a matrix. You use a matrix when you have a big case. Just to make sure that we understand, because we have seen oral-enteral communication before, but that communication that we treated was already closed. If your patient is coming like this, with oral-enteral communication in his soft tissue, first you should close it. First you have to use the chic fat. And then, when everything is fine, when you have no risk of infection, when the healing is finished, then you can treat with the sausage and the sinus graft. Not at the same time. So I can show you other cases, like this anterior one, this lateral one combined with the sinus, this mandibular one, and you can see that this technique is the easiest and the most predictable technique to treat knife-edge ridges with a horizontal defect. So this is the timeline. This is a timeline for your patient, because you need to explain them when you see them that you will do a 1-year treatment with 3 surgeries. First surgery is the bone graft. Then you wait for 6 months. Then you place the implant. Then you wait for at least 1 month and a half or 2 months. Sometimes you need to thicken the soft tissue or not. And very often you need to improve the keratinized tissue. So let's say free surgery. So the third is the soft tissue management. Then you do the uncovering. I'm not counting the uncovering as a surgery because really it's 2 minutes. It's really just an incision and you place your temporary abutment. And then you can do the prosthetic steps. So the patient has to know that and to say okay, to follow you for that. Why don't we do the uncovering at the same time as the combination soft tissue grafting technique? Because sometimes I can see many dentists showing this. And this is a great case to show you why. Because strip plus simultaneous uncovering leads to recession potentially. Not always. Sometimes you will do a case and it will work perfect. But it's not predictable. And this case is explain this perfectly. I had a distortion, so I did a strip technique and I did the uncovering at the same time. And from this moment you can see that the thickness of the soft tissue, of the connective tissue is not the same. I don't know why, but still, you can see it. I try to cover it with the matrix. Doesn't work. This is the healing, and this is the end result. So at the end, the color are not aligned. And if I had done that in 2 steps, first the strip and then the uncovering, I could have aligned everything. So it's not a big deal, really. To do the uncovering is really 5 minutes. What about vertical defects? Is it possible to treat vertical defects with a resorbable membrane? Why not? So this is a small vertical defect, and we also have a moderate deficiency, horizontal. First we treat the sinus, and then we are doing the graft. So we place the mixture and we pack it very well because we have a challenge here. We are trying to do a sausage on a vertical defect. That is not the indication. So I pack it so well. This is the healing and the post-operative CBCT. And you can see that I was able to correct the vertical defects. And I was careful to really pack it so well on the palatal sides because I know that the tissue, the soft tissue pressure is very important on the palate. So I pack it so well and I have a square shape because I wanted to prevent the pressure. And this is after healing. But the good news is that we could keep the vertical augmentation. We still have the 4.4 millimeter. But at the palatal aspect, we do not have a square shape anymore. The pressure was stronger, and we have now a round shape. It doesn't matter, but I think it was very important that I pack it so well, because if I hadn't, I think I could have lost more because of the pressure, because of the palatal soft tissue pressure. So this is the soft tissue healing, and you can compare with the vertical level of the ridge at the beginning. The vertical defect has been fully corrected. The ridge is now flat. There is no concavity anymore, and you can check the quality of the regenerated bone. and the horizontal thickness has been restored too. But keep in mind that this case is a very favorable case because it's a small defect, small vertical defect, just 4 millimeters. It's just a 2 teeth defect, and it's in the posterior maxilla. So it's a place where the regeneration is easier. You cannot do that at the mandible, you cannot do that at the entire area. Because it's a vertical defect, and we will develop this later, you have to do a secondary mini sausage. So it's another graft. Then this is the healing, and this is the soft tissue. And this is how it looks like. We don't have any keratinous tissue on the premolar. We don't have any keratinous tissue in the middle. No keratinous tissue on the molar. This is a beautiful patient. I wanted a beautiful result, so I took it from the labial side to the strip from the vocal side, and I placed it even up to the molar because you don't have any keratinous tissue, so you have to hope that it will develop by itself. This is the healing and the 3 months healing, and you can see that we have a good matching, a good texture matching of the labial strip. It's really one of the strong points of this technique. So then we proceed with the uncovering, and we want to preserve the mini sausage bone. This is now mineralized, and that lies above the implant. This is the bone, and you can easily understand that if we screw and then screw at this level to do the prosthetic steps, you won't keep your bone that is up, for sure. So that's the reason why we place a small abutment with a proof connection to distance the bone from the prosthetic interface. And then you can screw and unscrew on the top. When you want, the bone is protected. This is the final result with the bone peaks that has been kept above the implant collar. Stavros Pelecanos explained this concept perfectly in his latest publication, and you can of course also use a tissue level implant even better. But above all, for prosthetic reconstruction, you opt for zirconia or for anodized titanium. Otherwise, you cannot have a soft tissue attachment. If it's not polished zirconia or titanium, the cells from the soft tissue cannot stitch. You cannot have a cell attachment. If you don't have a cell attachment, you will have a pocket and you will lose the bone. So it's very important that you did a graft, you did a soft tissue graft, you need to replace your implant, you're happy, and then you destroy everything with your own prosthesis. So it's really something you have to take into account when you go for this kind of surgeries. This is the picture what it did with the polished zirconia here, and then you can place your coloring and the makeup. Maybe we can have a break. Is it
Gì chưa? Nói gì đấy? Xin lỗi.
Thank you for your sharing.